Fossati, who was normally planned for the first session. So Piero, we thank you so much for accepting our invitation. It is such a pleasure, in fact, to have you here with us, and we thank you for taking some of your precious time to lecture our students. So Piero Fossati graduated in medicine and surgery at the University of Rome in 2002, completed his specialization in radiotherapy in 2006 at the University of Milan, and completed his training in particle therapy at the National Institute of Radiological Sciences in Chiba, Japan, in 2007 and 2009. He has participated in establishing clinical operations with protons and carbon ions at CNAO in Pavia, Italy, and he is now the head of the carbon ion program and the scientific director of MedAustron, which is in Wiener Neustadt in Austria, as you might already know. His main interest is the clinical use of carbon ion radiotherapy, focusing on producing high-level evidence for established indications and exploring new potential applications and synergies. He is the co-author of the ICRU report on carbon ions radiotherapy. Dr. Fossati, it's a pleasure to have you, and we give you the floor.
Thanks a lot, Nicola, and apologies to you and to all the participants for the inconvenience, and thanks especially to Angelica that could cover my talk that was not delivered in time, but we could eventually find a solution, so I'm happy for that. So today we are going a little bit to talk about how to develop further the field of carbon ion radiotherapy, or more in general, heavy ion radiotherapy, so whatever is heavier than protons in a clinical setting. Nothing to disclose. So the idea is, where do we go next? And I think we have two main pillars with carbon ion. But before going into where we go next, let us very briefly, remind us why do we like carbon? We like carbon because we believe it can be better than dose escalation. So this is animal data from the KFZ, so from Heidelberg, and you see for a rat with a human well-differentiated prostate cancer that there is not such a big difference between the blue curve, which is the dose response curve in the animal model with protons, and the carbon ion red curve. So of course, carbon ion has higher RBE, but a well-differentiated prostate cancer is not so difficult to kill. So you just need to give a little bit less dose. But what is interesting is that the dose response is very steep. And when we go to the second one, which is moderately differentiated prostate cancer, then it becomes much harder to kill with protons. So you see that the dose curve moves to the right, but most importantly, you see that the dose curve becomes much more shallow. And you can see that carbon ion is not really moving much. And when we go to purely differentiated prostate cancer, then the curve is again steep with protons, but it's far away to the right. So if you want to treat with protons or photons, then you have a wide range of doses. And most of the time, you don't really know what's inside the patient. So of course, you can have high differentiated or poorly differentiated tumors, but they are always heterogeneous. So you don't really know, should I apply the higher dose or should I apply the lower dose? And even if you have a pretty uniform tumor, well, the curve is still not so steep. So in order to kill the last cell, which is radioresistant, that will eventually cause the recurrence, you have to give a higher dose and damage more the healthy tissue. With carbon, instead, the dose range is much smaller. So the reason why we believe carbon is good is not really because higher B. You could get higher dose instead of higher B, and the idea would be just the same efficacy. The reason why we like carbon is because of this smaller variability. So you don't really need to bother to understand what's inside the patient, which is always very challenging, because whatever biopsy you take is always a partial picture of reality of that tumor in that patient. You just can count that because of its intrinsic radiobiological properties, the variability in response is less. So we believe carbon might be better than dose escalation, because you don't really need to treat all the healthy tissue to high dose just to kill that last radioresistant cell. You are using a radiation which intrinsically solves the problem of the subset of radioresistant tumor cells. we have very nice results, clinical results from Japan and from Europe. And in some indication, it was really a game changer. So mucosal melanoma, if it is not operated, could be treated with radiotherapy, normal radiotherapy, and there are also nice responses, but those patients eventually will recur locally and metastatic and die. And this 79% 5-year local control and 1/3 alive at 5 years without surgery, this was then reproduced by the cooperative Japanese data. This is really something that we don't see with any other modality. Head and neck, bone and soft tissue sarcoma, again, if you do not operate, you don't really have long-term survival, and with carbon, very nice survival. Paranasal sinuses and salivary gland tumors, inoperable sarcomas in other parts of the body. So we know from the bulk of existing clinical data that there are diseases that cannot really be cured, in which you do not attempt any cure except with this modality, or in which you attempt a cure with surgery, which is very mutilating. So there is a precious already existing clinical knowledge. And we have seen this clinical advantage in several tumors, but mostly in these that I have listed. So in head and neck tumor, but not the 90% of squamous cellular carcinoma, which is quite well treated with standard radiochemotherapy, but in the 10% of all other rare histology in the head and neck. We have seen a significant role for carbonion in sarcoma, all those sarcomas where you cannot achieve a macroscopic gross resection. Well, of course, there are exceptions. There are very radiation sensitive sarcoma like rhabdomyosarcoma in Ewing, but the normal sarcoma, especially osteosarcoma, chondrosarcoma, and other histologies in sites of the body where you cannot achieve a radical resection, then we have carbon as a potential curative. We have seen excellent results in pelvic recurrence of rectal cancer. Again, this is considered an indication for palliative radiotherapy if it cannot be resected, but we can treat it with curative intent with carbonion. And we have seen a very intriguing advantage in terms of survival, biochemical relapse-free survival, overall survival, and prostate cancer-specific survival. So all the endpoints, of course, prostate is one of the big indications for radiation, and it is excellently treated by existing modalities. We are just focusing on the small subset of very high-risk tumors. So the worst prostate cancer, apparently with carbonion, has an advantage compared to the best results reported with any other kind of radiation or surgery. And the last of the list, pancreatic cancer. So this is a list of already success stories in which we would like to have better evidence, more convincing evidence to build more centers. And I think we are a little bit in this situation in which we would need more centers to eventually produce the evidence, but we would need more evidence in order to build more centers. So it is on us to do with the limited available resources and with the limited available treatment slots. I mean, the colleagues in Japan have created this J-Cross. J-Cross is a cooperative network of several of all the Japanese carbonion facilities, and they are doing multicentric prospective trials. And in Europe, we still have a little bit to learn from that. We are going each by himself, but there are efforts to create something similar in Europe. And so far in Europe, the main leader in terms of clinical trials has been University of Heidelberg, and they have. My point is that we should have diversity. We should have several different approaches in conducting this trial, and of course we could do with more cooperation in Europe. Now there is very recent the news which many of us finds extremely interesting and also surprising, that we are struggling to build just one facility. So in the US, after 10 years, finally, they are building the first carbonion facility, but it was a major challenge with several pitfalls and failed attempts. And right now, as we speak in China, they are not designing, they are not thinking about, they are building 6 carbonion facilities. So there is also this new geopolitical environment in which we will have to try to establish cooperation with the new Chinese facilities and see how they want to use them. So for me, the path forward, as I was trying to say is should rely on two parallel approach. The first one is we should really strengthen the level of evidence about the good results that have already been proven. So far, most colleagues in the mainstream radiation oncology or oncology would say yes, but this is still a single institution, non-randomized. There can be major selection bias. So we need to produce a stronger evidence, at least for one or two indications, to convince more people that this treatment is really advantageous for the patient, and this will lead to more facilities, and more facilities will really lead to more evidence. So this is, for me, the way to break the sort of vicious circles is to be able to have at least one positive, convincing, easy trial in one easy indication. We tried with pancreas. I have to say we failed. Now I am more and more thinking that we should pick the simplest of the lot, which could be prostate. High-risk prostate could be something that convinces many people to build more facilities. But this is not the whole truth. Of course, there have been a major success history. We want to convince everyone they are true and reproduce them and get this modality to all the patients that we already know can benefit from it. But we also want to explore new uses. And I'm going to talk to you about these three possible new approach. So the role of carbon to induce reoxygenation, the better and more clever use of a high LT component in carbon, and possible synergy between carbon and immune response. About the first traditional approach, how can we convince people that the results are true? Well, the basic, the most simple and most well accepted way would be to produce at least one successful randomized phase 3 clinical trial. There are major hurdles to that. The patient do not want to be randomized, and no one wants to pay for the randomized clinical trial. So far, it has not happened. There are several clinical trials in Heidelberg especially, but none of them is carbon ion versus another modality for an endpoint which is convincing for everyone, like local control or even better overall survival. They are mostly carbon versus protons, but the real thing is to prove that carbon is better than another modality which is mainstream. And this is not happening so far. I would like to show you just one example, which is so far quite successful, which is the SACRO trial, focusing on sacral chordoma and trying to prove that the Japanese data. Let's go back for a couple of slides. Here you see this was the sort of revolution. Colleagues from NIRS, now QST, so Dr. Imai, the upper row, published results of sacral chordoma that were not inoperable, that could have been operated, but were treated with exclusive carbon ion. And she could have, at 5 years, more than 80% local control, and at 10 years, more than 50% local control. And this is very similar to what you get after the big mutilating sacrectomy, so that the very invasive surgery. So according to this, most orthopedic surgeons have started to say, well, we can avoid this procedure, which we don't like because it is very long, complex, full of morbidity, and the patient had tremendous side effects. Let's do carbon. But some surgeons say, no, we have to prove this. And we all recognize that it's very hard to randomize patients between an invasive procedures like sacrectomy. It can be a 10-hour intervention. You can lose 5 liters of blood, and you can stay in hospital for 3 to 6 months, and you have massive problems of massive risk of serious complication. On the other hand, they say this is the most proven and best results in terms of survival. And the other procedure is completely ambulatory and non-invasive. So we know from experience that patients do not want to be randomized between such different things. So this SACRO trial is designed in an innovative way. We are allowing prospective cohort in which the patient is allocated to surgery or to radiotherapy according to patient wish and to physician judgment. So this will be treated in a prospective way, but there is at least no selection bias because the patient is first enrolled in the trial. So it's not like we are selecting only very good patients. I mean, if we are selecting here when we do eligibility. Of course, there can be a bias in allocation to one or the other arm. How we try to correct for this bias, we are using the prospective cohort to produce a pre-test probability. So this is a Bayesian approach. The idea is, if we look at retrospective data, it looks like the results of surgery and carbon ion are the same in terms of control, and possibly carbon is better in terms of toxicity. But this can be because they just selected the patients. So the population could be very different. So we just have one point of access. So we reduce the variability. Then we arbitrarily, according to our judgment, put in arm A or in arm B. So there is still a selection bias, but it is a more controlled group. From this cohort, we will produce a pre-trial probability. So if they have very similar local control, we say, okay, even if you just take the same group of patients and then select, there might be a selection bias, but it looks like the same. How do we check that this is really the same? We need to verify that the pre-test probability with a small randomized sample. So this is really the prospective Bayesian design. You start with something which is a pre-trial probability from the trial, and then you verify with a very small sample of randomized patients. This was the idea, and it was because colleagues from UK and from Scandinavia said, well, we have not experience with this modality, so we don't really know if it is better or worse. We are willing to randomize patients. The study should really compare relapse-free survival. So can we really be as effective as surgery with carbon ions? And it has been very successful because there are 7 countries, all of Europe plus US and Japan enrolling patients, 23 centers. And this was the interim analysis last year, and we had enrolled 90 patients, and now they are more than 100. And please remember that this is a super rare disease, that there are basically 3 sacral chordoma per million inhabitants every year. So in Europe, there are very, very small numbers, and we could select most of them. So this was a very big success. The failure of the trial is that despite the optimistic idea that the patient from UK or Scandinavia would be randomized, so far of the enrolled patient, no one has been randomized, 0. So we have prospective comparison in which we stratify according to non-confounding, but still the unknown confounding bias is not corrected by the randomization because no one accepted to be randomized. And so far, we have seen that relapse-free survival is the same for surgery and sacral and carbon ion and the proton therapy. So this is quite interesting results, but it is just the interim analysis. We need more time. We will not be able to say randomized confirmation, but at least we will be able to say prospective confirmation that carbon is the same. The other things I wanted to tell you about this is that we are really exploring toxicity, and it turns out that there is indeed non-negligible grade 3 toxicity from carbon ion, but still this seems to be less than with surgery. So this is just to present you a very nice ongoing European cooperation. We hope this could be a sort of a start to build a stronger cooperation among European facilities, but not only among carbon ion European facilities. The good thing of this trial is that it involved the whole sarcoma community, and this innovative design could be used for other indication. I'm, for example, thinking about hepatocellular carcinoma, where randomization is not so critical because the available procedures are normally not so invasive, and at the moment hepatocellular carcinoma is not really considered as a standard indication for proton or carbon in Europe, despite the very interesting evidence coming from the US and from South Korea. So a poor randomized trial might be difficult, but a Bayesian trial with prospective cohort and a small randomized sample could be a nice way to go for hepatocellular carcinoma. So that was just one point of view, which is not the complete picture, but is an additional building block to just let you know what we could do to produce stronger evidence. Let's now switch to the other pillar, so new uses of carbon ion, and I would like to briefly tell you about three potential new developments that are happening and that we would like to happen. The first one is lead painting. Well, you can call it however you like, but the issue is we are all aware that carbon ion is not a high LET modality. High LET modality is fast neutrons. Carbon ion, in our hope, is high LET in the tumor and low LET in the healthy tissues. So the optimistic qualitative way of thinking of the medical doctor is I will have the same high efficacy of fast neutrons, which we know were very effective, without the horrible toxicity of fast neutron, but with the very nice low toxicity of protons, because I will deliver something similar to protons to the healthy tissue and something similar to fast neutrons to the tumor. This is, of course, simplistic. And what we know is that the bigger the tumor, the smaller the proportion of the tumor that will really get a lot of very effective carbon ions from the distal part of the single monochromatic beam. The other thing that we are quite well aware is that if you just optimize according to RB weighted dose, you have no control on which portion of your target will receive a lot of high LET and which portion will not. And what happens most of the time is that the high LET goes where you don't need it and does not go where you want it. So RB weighted optimization is based on the only thing that we can measure with accurate enough precision, which is just cell line survival. And if we look at cell line survival for different particles with different LET and with different cells, this is a GSI open access, very interesting database in which we can see that each experiment is one point of this graph, and we see there is basically a bell-shaped non-monotonous relationship. So if you have low LET, this means that your ionization density is very sparse, is much sparser than the DNA double helix. So the possibility of one ion producing a lethal double strand break is very little. So you have RB, which is almost the same as photons. And when you increase the LET, you make the ionization pattern denser and denser, and you reach a maximum in which ionization pattern is really so dense that the mean distance between two ionization events is comparable with the DNA double helix diameter. So each particle has a fair chance of producing multiple ionization of breaking multiple chemical bonds in a small space of 3-4 couple of bases. So it is highly likely that one particle will produce one lethal double strand break. So this is high RB. What happens if you increase again the LET? If you increase again the LET, you decrease the ionization pattern, and you have even denser ionization, and then RB goes down. Why does RB goes down here? Well, for two reasons. On the one hand, you are wasting energy on already dead cells. And on the other hand, at one point, each ion transfers so much energy that you might reduce the number of ions so much that some cells get zero. So no matter how effective is your ion, if one cell is not hit by at least one ion, it will not be killed. So this happens at really high LET. Now, when we look at RBE, RB-based optimization is simply absorb physical dose times RB, and the RB is calculated according to the mixed field of particles in a complex way, considering how much is low LET, how much is high LET there. And this will mean that for the RB weighted optimizer, it is the same if you have too high or too low LET. But in reality, it's not the same at all, because too high LET might be low RBE for that particular experiments, but this will be very high RBE for the tumor cells, which is 10 times more radioresistant than you were thinking. So there is a big value in this part of the beam, which is not accounted for in the RB weighted optimization. So we were thinking big tumors do not get a lot of high LET because in big tumors the high LET component will be delivered to a small percentage of the tumor, and this will result in suboptimal control. And this paper has been out since 10 years. a very large difference in local control if you treat an osteosarcoma, which is still big. Half a liter of osteosarcoma, no one would call it small. Half a liter of osteosarcoma in the pelvis that is not operated and can be controlled to more than 80% is almost a miracle, if you want. That were the Japanese results with carbon ion. But if you go from half a liter to 1 liter, 2 liter, then your more than 80% becomes basically 10%. So there is a huge loss of control with tumor size. And at this point, 10 years ago, we had a debate in which some of us were saying, this is because you don't give the high LET to the big tumor. And some other was saying, no, you say so because you like to play with LET because it's fun, but the reality is much simpler. Big tumor, bad results. It has nothing to do with high LET, and that was an open question. But now we have accumulating evidence that no, it was not only because we like to play with high LET, which of course we do, but there was some truth in the statement that poor tumor control has not only to do with the bad prognostic factor of size, but has to do with the lack of high LET in a part. And we know this from several clinical data. Pancreatic cancer was analyzed by Dr. Hagiwara. He also spent some time with us, and now he's in Yamagata, excellent new generation of Japanese carbon ion doctors. And he demonstrated that RB-weighted dose does not correlate with local recurrence in pancreatic cancer, but LET does. So if we trust our RB model and we think that putting a lot of low LET will be the same as putting a little of high LET, well, it turns out it is not the same. If you put a lot of high LET in the GTV, you don't see the local recurrence for pancreatic tumor. But if you put a lot of low LET, you do see the recurrence. So there is a value in high LET, and this was shown for pancreatic tumor, and this was shown for chondrosarcoma, in which again it is that the lack of high LET that correlates with relapse or with lack of local control, and not the lack of RB weighted dose. And this was shown for chordoma, and this was shown both in the Japanese experience that use one RB model, which is the modified MKM, and in the Italian experience, which shows another RB model, the European one, which is the local effect model. So we have accumulating evidence that says that yes, it is important to put the high LET in the tumor and not simply trust your model. And if you don't do anything, what happens is that normally the high LET will go exactly where you do not want it. This is a 3 fields carbon ion plan for the sacral chordoma, in which you just tell to optimizer to have the best dose in the tumor, the best RB weighted dose in the tumor, and to spare the rectum as much as possible. So what happens is that the system will use all the beams to go all the way, and they will stop at the border between the PTV and the healthy tissue. And the two opposed beams will somehow compensate each other and things will be smeared out, but you don't want to treat with the posterior anterior beam and go through all the bowels. So you will have the posterior anterior beam that will stop. And this will mean that the bulk of the tumor will get very little high LET, and the rectum will get all the high LET. So this is what happens in the patients we treat. The good results we have seen clinically have been obtained by using the high LET, not really in the best possible way. So what we would try to do, and it is several years that we say that we want to do that, is to optimize not only the RB weighted dose, but also some low-level physical quantity, which could be the LET. And these two plans look similar, but not identical. The upper one is the normal plan, and you can see this 70% ISO dose, which is more confined to the target. But if you want to put the LET inside, then you have to stop the beams before, and this has a price, and the price is higher dose in the entrance plateau. So you see this ISO dose, the yellow one, which goes farther up. But the gain that you have with this price is that you move the high LET inside the tumor. So it is possible to do that. Yes, of course, if you want to do that in the most optimal way, theoretically, then you would need a multi-ion dose painting and LET painting. Well, you don't really need it. If you have 3 beams, not so many, just 3 beams and only carbon, you can still steer the LET and put it where you want, paying a minimal price in terms of worst dose distribution of RB weighted dose. So LET is, and this is another debate, possibly not the quantity that the medical doctor likes the most. What we want to do is to have some effective, highly effective radiation, so some high LET, but we don't need it everywhere. We know that it will be very hard to have it everywhere. We need it in most tumor voxel, and it must be enough. So the statement that we need most tumor voxel to receive enough dose with high LET is what we would consider as a sort of user requirement from the medical doctor. And now we are trying, and this is an ongoing process, to find a low-level physical quantity that will enable us to put some quantitative meaning to this most, enough, and high. And at the moment, we are looking at dirty dose. This was an idea we had, I and some of the colleagues in CNAU and now here in Medaustron, and what we wanted to explore was, considering that there is a value in the high LET even at low RB, we wanted to explore the percentage of physical dose that is delivered at the high LET with a threshold to be optimized. So the dose average LET is the center of mass of the LET spectrum. But the dirty dose is the area of the LET spectrum which is right of a given line that you can put at the best threshold that you have to define. So they are similar but slightly different quantities. If we look at this dirty dose, on the one side, this makes optimization much easier because it is not really an averaged thing, it is just a physical quantity. If you have the LET spectrum, you already have the dirty dose without any additional calculation. And the other thing, it turns out that this same concept was used by the proton community in the attempt to avoid excess toxicity of the distal edge of the proton. So all the commercial system had it for protons, and we are trying to develop it now together with the TPS vendors, so research for carbon ions. And we are trying to compare the distribution of this dirty dose when you change the lead threshold, and we are trying to compare small sarcoma and large sarcoma, and we see there is a difference. What happens when you change your threshold is that, well, if you say which percentage of the dose is delivered at the LET higher than 1 keV per micron, well, basically everything is delivered at higher than 1 keV per micron. So you will have all the voxel with 100% dirty dose. And if you ask what happens if you look at which percentage of the dose is delivered at higher than 3000 keV per micron, well, none of the voxel will get known at higher than that. So everything will be 0%. So when you move your threshold, at one point you will see that some voxel have dirty dose and some don't. And the threshold that really maximize this spread of the distribution of dirty dose is different from small and for big volume. So you see that for now that here the scale is wrong, but for big tumors, you have to go just be higher than 20 keV per micron, and you start to lose voxel with dirty dose. But with small tumors, this happens only with 35 keV per micron. So the first results that we have to verify and confirm is that there could be a very low threshold for high LET in terms of dirty dose. So we are going to look possibly at how many voxel receive enough percentage of the dose with a LET higher than 35. This 35 is the new number that is coming out and is still not final. And then how many and how much, this is also something we hope to find out comparing small and big tumors. In the meanwhile, what we are able to do, because the dose average LET is not available in clinical setting and will not be for at least 1 year, we can do a poor man optimization. So we just block the beams artificially so that they don't go all the way. And this again means that you pay a small price in terms of more dose in the entrance, but you can put the high LET inside. If you put the high LET inside, you pay basically no price in terms of conformality if you look at cold spots. If you look at cold spots, what turns out is that the index describing how many cold spots stay the same. So here blue means the original LEM are the weighted dose that we use for planning and optimization. But the interesting result is that we have a improvement in the MKM distribution. So you plan with LEM, then you compute with MKM, you find out that the results are not so nice. Of course, they are different model. But if you do that with blocking, then the results of the model you didn't optimize becomes better because you put the high LET in, and this means less cold spot in the target. In terms of hotspot, it's the opposite. The hotspots do not become much worse in terms of the system you use, so that the blue LEM, but the hotspots become much worse in terms of LEM. So you might say, okay, if you do this blocking, you will have horrible hotspot inside the targets. You should not do that. Well, honestly, when you plan and optimize with LEM, you always have hotspots when you recompute with MKM. The point is that if you do with this blocking strategy, they will be in the target. But if you do without the blocking strategy, the hotspots will be outside the target. So honestly, this is a quite safe approach to remove these very hotspots from the healthy tissue and bring them. And then eventually, we don't know if LEM or MKM is more accurate, and it might well be that for one patient, one is better, and for the other is better, and we will possibly never really know. So having a strategy which brings the high LT inside the tumor and as an unexpected but nice results, also optimize the treatment in both modalities is, I would say, quite nice. The sacral chordoma we have treated in Medaustron, also inside the sacro trial. We have paid more attention to all these aspects, and our results are so far much better than the sacro trial. So we had only one local recurrence out of 23 patients, sorry, out of 18 patients. So this is interesting, but of course we have to wait longer follow-up. What I wanted to share with you is that when we did this dirty dose analysis in the sacral chordoma, so here red is a big tumor and green is a small tumor, there was one big tumor that behaved in terms of dirty dose distribution at varying lead threshold like a small tumor. You see that normally all the red are together and the green are, so there is a difference between small and big tumors, but one big tumor was behaving like the small one. And this was this patient, which was a young girl, in which we wanted to preserve fertility. So the tumor was like that, the ovary was here. To preserve fertility, you have to reduce ovary dose to less than 2 gray or 2.5 gray. And this means that even the fragmentation tail of the vertical beam would have been a problem. So this resulted in a very inhomogeneous spot distribution, which somehow was already a sort of gross unintentional blocking and resulted in more high LT inside the tumor. And this resulted in a dirty dose distribution comparable with small tumors. So this was a very indirect but promising hint that you can really optimize your plan in such a way that even the big tumor will have an LT or dirty dose distribution similar to the small tumors. By the way, we are recontouring sacral chordoma at each follow-up, and this patient was really behaving much better than the others. So the high LT inside the tumor in this single case, which is just an anecdote, correlated with the faster tumor shrinking. So really, after discussing about these ideas for several years, we are finally at the stage in which we are starting to go clinical. And now the debate is if we should, by the end of the year, start treating patients with this blocking, or if we should wait for the real LT optimization available as a full-blown medical product, which will take 1 more year. Now, let us very briefly, because we don't have so much time, touch about the possible synergy about carbon ion and immune response. You all know that more than 10 years ago, there was this pioneering and visionary idea of using radiation as in situ vaccination. So you irradiate the tumor, not to kill the tumor, but to kill some of the tumor that will produce antigens and will produce a lot of other things. Some of these other things are signals that will tell to the immune system, okay, let the thing in peace, it is not an enemy, and some other will tell to the immune system, no, this is very bad, you should eat it. So we have in situ vaccination producing antigens, and we try to maximize the immunogenicity of this event. And there are some excellent results in which you treat just one lesion with radiation, and after treating one of many lesions, all the other that you have not treated disappear. So this is like a miracle, and indeed it is like a miracle because it happens in one patient and does not happen in the other 99 patients. So we have very nice results of immune modulating drugs. We have very nice results of radiation, but immune modulating drugs are at best successful in 30% of the patient. Abscopal effect with radiation is at best successful in 1 to 2% of the patient. And then we want to combine them and maybe do something different to increase this percentage from 30 to 80 or 90. So this means that we have to do better than normal radiation, and this means that we have to try to exploit all the advantage. One advantage is that with particles we treat less volume, less circulating blood, less lymph nodes, less spleen, so we induce less lymphopenia. And you can see that this is a number of lymphocytes, aberrant lymphocytes after carbon and after X-rays. So when you treat with X-ray just one fractions, you damage a lot of lymphocytes. When you treat with carbon, those that are damaged in a much worse way. So they are full of really monstrous chromosomes, pluricentric, etc., etc. Those damaged with carbon with X-rays are typically just one deletion. But the point is that because you treat less volume, you damage less lymphocytes with carbon. And then the other thing is that the surrogate endpoints that tell us how immunogenic is our treatment. Well, with carbon, we are able to produce apparently a more immunogenic, or with high LET, we are able to produce a more immunogenic kind of cell death. Here you see at ISO survival, so same survival between low LET and high LET for different cell types, but all the surrogate of immunogenicity, the black bar is higher. So it seems that the RBE for immunogenicity is higher than the RBE for cell killing. Well, this is promising, and this could have to do with the fact that with carbon you produce more DNA that is damaged and goes in the cytosol, so not in the nucleus. And DNA in the cytosol is what we call viral mimicry. So the cell is tricked into believing that there is a viral infection, and then activates this cGAS STING pathway, which will stimulate an immune response. And we know that with high LET, you have more and more micronuclei and cytosolic DNA, so more viral mimicry. All this fits very well together. Now, how to use it? It's not so clear, and we would need a lot of preclinical research, but this is extremely complex and expensive to do. What most people are doing is they are just moving to clinical research, trying to exploit what they have. And what we are doing now is with a colleague, Dr. Tubin, that developed this concept for low LET irradiation, so SBRT with photons. We are trying to just target the central part of the tumor, which is normally hypoxic, and this is based on the assumption, which is supported by preclinical evidence, that the hypoxic segment will produce more immunogenicity and more immunostimulating signal, and we try to spare the outer rim of the tumor, which is better oxygenated, and there are preclinical evidence that this better oxygenated part of the tumor will produce more immunosuppressive signals.
So you have 2 minutes left, Dr. Fossati.
I think we have to skip one topic, and we just finished this one. We have an ongoing trial, and we recently reported on I just show you one case. We recently reported on the first 11 patients. So the idea is we just treat the center of the tumor. We use the outer rim of the tumor as a spacer, and we protect the peritumoral immune microenvironment. And this leads to some very interesting response. I just show you the first 11 patients. They were all heavily pretreated with very bulky tumor. And in some cases, we could achieve a very good palliation. So this here, you see, this is all tumor in the left side, and the clinical picture shows all tumor. The patient was bleeding, really a pre-terminal and not really able to swallow. And we had a wonderful response with several months of good quality of life. And in some cases, we saw an abscopal response. So the idea is maybe carbon has an advantage in terms of synergy with immunogenicity, but there are several ways to exploit it. At the moment, we are just treating the center of the tumor. You understand that there are possibly many other ways to deliver a spatially fractionated carbon ion, and we don't know which is the better, and we will need clinical, preclinical animal research, but we need a reliable animal model, which at the moment is extremely problematic. Last topic would have been reoxygenation, and I hope I get another invitation to the next course to discuss that topic, which we couldn't cover today. So now I will be happy to take questions.
Okay, so Joe, can you manage, will you be managing the questions, please?
Okay, so is there any questions from any of the students? Any raised hands? can't see me so far. Don't be shy, guys.
I actually have a question myself. I was wondering, so far, insurance companies are not really considering ion therapy part of their programs to cover, and this is creating sustainability issues when it comes to ion therapy facilities and even building more facilities. This is something that you touched on at the very beginning, in fact, of your talk, where the dog is biting his tail and so forth. If one were to consider the rate in which we are doing and working on these clinical trials, and considering also the number of patients that are being recruited for these trials, at what point do you think will we be in a position, the tipping point, to go towards where we'll be able to show in real practical terms that the clinical trials are strong enough and there's hard evidence that ion therapy is enough proof, in fact, clinical, in fact, proof that it is effective enough to justify insurance?
It's a very complex situation. So at the moment, especially in Europe, we have extremely different approaches. Insurance companies and national health systems are indeed covering particle therapy with proton and carbon, but with very different approaches. There are basically 3 approaches in Europe. The first one is that, let's say, Italian one, which is also similar to what they do in Germany and what they do in Denmark. So there is a list of indications based on the critical evaluation of existing evidence, which is no randomized evidence. And then they say, we will pay for sacral chordoma, skull-base chordoma, adenoid cystic carcinoma, a list. You are in the list, you don't have to prove anything. You are out of the list, you don't get paid no matter what. Then there is the Netherlands approach, which is model-based. You are paid if you can prove with the comparative planning study that there is an advantage in your better dose distribution. But this advantage is just focusing on toxicity reduction. So it applies for protons and is completely unusable for carbon, where the advantage would be higher local control, and we have nothing like a reliable model. And then there is the Austrian way, which is partially also the German way, in which the approval is based on the expert evaluation, so external tumor board of people that have no financial interest because they are not going to get paid for the treatment, but they are expert in that tumor and they recommend that it should be treated with particles. So all these systems are taught in a way that they should finance the existing particle facility that have been planned basically at the national level. So each country does not want to see their own particle facility go bankrupt, but they also want to somehow prevent the proliferation of private particle facilities. How do you do trials in that? Again, it is very different. In Austria, for example, if you need a tumor board recommendation that says this is the only and best option for the patient, then you cannot really randomize, because if you're sure, and you must be sure to get paid, that you cannot randomize. In Germany, they said, well, we understand that it is not true, so that the Krankenkasse system, the insurance system in Germany will pay for trials. But the problem is that those trials are mostly done inside the particle facility. Very interesting is the Danish approach, in which they have the list, a short list of indication in which you pay like pediatric tumor with protons, etc. But they say all the rest can be paid only if it is inside the trial. I think this could be a very smart approach if we could copy the Danish approach. If we say, okay, you can treat other disease or an innovative approach, but you are forced to do that. We will pay for the trial because no company is paying. The other thing which is missing is, honestly, pharmacological trials have the support of pharmacological companies, but we have no support from industry. And all the vendors, I mean, I think it would be very viable and financially sound investment for accelerator vendors to sponsor a trial. To sponsor a trial, you need to invest something like from 2 to 6 millions. And if you just think about the cost of one, so if one trial gives you 10% probability of selling one more machine, then you should do it. But it's simply not in the culture of accelerator vendors to sponsor trial. And this is not easy to change in 1 year or in 10 years. So I have no solution. I just try to outline my point of view of the problem.
Thank you so much. Thank you.
Thank you. We also have a question in the chat from Julie, and that is, how do you delineate the most hypoxic region of the tumor? And is this based on hypoxia PET, e.g. FMISO?
In the trial of Dr. Tubin that we are running at the moment, yes, it is based on FMISO, but the reality is that we have preclinical data showing that the hypoxic part is more immunogenic and the normoxic is immunosuppressive. We are treating the center because of that, and we are seeing some nice response. Now, is it really because of hypoxia, or it is just because we are treating the center? I think this is still an open question. So this is just one of the many possible strategies. We are doing this because it has been established with SBRT, and we are doing this based on hypoxia. We are not doing a lot of other things that could be possible, like inhomogeneous dose prescription inside the center, or grid, or a mix of grid plus center plus inhomogeneous. I mean, there are so many variables to try.
Brilliant, thank you very much. And we also have another question in the chat, which is from Valeria, and she says that whether or not hybrid solutions may exist, and if or not, if they are studied, for instance, combining the different techniques to maximize the advantages for each, maximize the advantages that each therapy provide.
You say hyper what? I missed the word. The question was if hyper something exists, but I missed.
Oh, sorry, yeah, whether hybrid solutions exist, and if they are or not studied to maximize the advantages.
Oh, here it is, hybrid. Yes, there are. This has also a little bit to do with facility design. All the Japanese facilities, except the one in Hyogo, are carbon only, and so they treat with carbon. But all European facilities are dual facility of proton carbon. So we are sometimes mixing proton and carbon. So we treat proton for the larger volume at risk, and then carbon for the boost, and this makes a lot of sense. So a mix of proton and carbon exists, and sometimes we mix proton and photons. So this could be very well explored, especially in terms of the topic we could not cover because I was too slow, which is hypoxia and reoxygenation. That would definitely be only a carbon boost, anticipated carbon boost together with other modalities. In terms of mixing, we do 7 days carbon and 1 day protons, or something like that. But what would be very interesting, and at the moment we are lacking the tools to do that, is to do in the same treatment session a mix of carbon and protons to really shape the dose and the LET. And that at the moment is not possible. There is no clinically validated TPS to calculate that, and it's just a research question, but a very interesting one. In terms of mixing high LET or protons with systemic drugs, there is still a lot of work to do because we are just extrapolating from photons experience, and there is little or no attempt to really target with drugs the specific pathways that are relevant for carbon ion. Just to give you an idea, we knew that photon irradiation of head and neck cancer led to hyperexpression of epithelial growth factors. So there was the rational attempt to combine radiotherapy with inhibitors of EGFR, so cetuximab, and this led to some interesting success. So now in patients that cannot tolerate chemotherapy, you use cetuximab instead of chemotherapy with its toxicity. And in Heidelberg, they try to do the same with carbon. But the point is that carbon does not really lead to a lot of hyperexpression of EGFR, but it leads to hyperexpression of other pathways. So we are not at the moment designing trials in which we use a specific drug that targets a pathway of carbon ion. That is again a research topic at the moment.
Brilliant, thank you. And one last question then from Chris Knaps.
Thank you for the nice presentation. I just had questions, I guess, regarding the slides where you showed the differences between the two RBE models. So my question is mainly, since there are differences between the local effect model and the microdosimetric kinetic model, so sort of those differences, are they more pronounced in like normal tissue regions or in tumor regions? And are there some specific like localizations, like, I don't know, are these differences more pronounced in like, I don't know, like prostate glands or head and neck? Or like, when do we care mostly about the differences between the two RBE models?
This is a very good question, but would require a very long answer or possibly another talk. We know that just two models are employed in the clinics. One is the one used in Japan, which was first the semi-empirical Kanai, and then the modified NKM, which are different but consistent. So let's say NKM is all the Japanese word, and in Europe it was local effect model. And there are a lot of differences, but again, it would require a much longer response. What we can say is that basically the biggest difference is at the end of the range of the monochromatic. So if you optimize with LM, what you find out in NKM is that where your beam is stopping, you have a hot spot, and in the middle, you have a cold spot. And the other way is true when you optimize with NKM, you realize that end of range, you have a cold spot when you recompute in LEM, and you have hot spot in the middle when you recompute with LEM. So this can be extremely relevant if you treat with a small number of beams. The two main way to prevent this uncertainty of the RBE model is using multiple number of beams. Ideally, you should always have a bit of contralateral contribution, not only coming from one side. And now we are exploring this new idea of optimizing LET, which will sort of make the difference between the two models less critical. But should be another presentation on the topic. It's not an exhaustive answer, and I'm not able to give an exhaustive answer in a few minutes.
Okay. Well, thank you for the insight. Anyways, thank you.
Are there any other questions? There don't seem to be other questions. Dr. Fossati, it was such a pleasure to have you. Thank you so much for giving us your time and such a comprehensive and interesting question. Yes.
Nicholas,
Madge.
I was just going to say to Piero, he said, hope we give him another chance to deliver a lecture for the others. Nicholas, Piero, we are waiting for the second course that we are running next year for you to be leading that course. So we are going to reach out to you and put it in your agenda.
Yes, and I hope I will be able to be on time and avoid this.
You'll be chairing it, so you will be on time, in person even.
Yes, with pleasure. So thanks a lot again. Apologies, and yeah, see you soon. Ciao, ciao.
Thank you, Piero.